Staring at a mountain of pharmacology flashcards, it feels like you're expected to memorize the entire medical dictionary by tomorrow morning. The Nursing Licensing Board measures one thing above all else: public protection. They need to know unequivocally that you won't harm a patient on your very first day. Let's look at a classic clinical scenario. You have a patient, Mr. Jones, who is post-op day 2 from abdominal surgery. You walk past his room, and from the doorway, he appears to be resting peacefully. He's using a patient-controlled analgesia, or a PCA pump, to manage his pain. This machine allows him to deliver a small, precise dose of IV medication by pressing a button. And there is a strict, non-negotiable safety rule you teach the patient and their family. Only the patient is allowed to touch that button. The PCA pump relies on a physical fail-safe. If the patient becomes too sedated, their hand goes limp, and they physically cannot push the button to give themselves more medication. Differentiating between a patient who is quietly healing and a patient who is quietly crashing requires objective filters, because a visual glance from the doorway will lie to you. You walk into the room and catch a well-meaning family member pushing the PCA button while Mr. Jones is asleep. They want to ensure he doesn't wake up in pain. This is called PCA by proxy, and it completely bypasses the machine's built-in safety limits, pushing the patient straight toward an overdose. This chart shows the Passero Opioid-Induced Sedation Scale, or PSS. It is an objective tool used to quantify exactly how sedated a patient is. If a patient is drowsy but wakes up and talks to you, that is an expected effect of the medication. But if they fall asleep mid-conversation, or if they are completely unarousable, they have crossed a critical threshold. This highlights an absolute physiological rule the NCLEX tests relentlessly. Sedation always precedes respiratory depression. The brain slows down before the lungs slow down. You evaluate Mr. Jones's vital signs, and the data confirms the worst. His respiratory rate has plummeted from a normal 16 breaths per minute down to a life-threatening 6 breaths per minute. When an exam throws a complex case study at you with 20 different abnormal blinking red lights, you have to filter out the noise. You evaluate the urgency by falling back on your ABCs: airway, breathing, circulation. If the patient is not pulling in oxygen, their pain level is secondary. Airway always wins. Staring at a patient who is barely breathing, the novice instinct is to panic, grab the antidote, and intervene immediately. But if the test says the patient appears sleepy, and you act on that subjective guess without checking their pupils or oxygen saturation, you might be treating the wrong problem entirely. The sequence of your actions must follow the AIR rule: assess, intervene, reassess. The expert discipline is to pause and gather objective data first. You physically check the respiratory rate, listen to the lungs, and verify the oxygen saturation before you define your intervention. Once you confirm the respiratory failure, your very first emergency action is to call for help. You hit the staff assist button or call a rapid response, but you never leave the patient's bedside. Because Mr. Jones is deeply sedated, the muscles in his throat have relaxed, allowing his tongue to fall back and occlude his airway. You manage this by immediately performing a jaw thrust. Place your hands behind the angles of the lower jaw and lift forward to physically pull the tongue away from the back of the throat. With the airway open, you reach for the ambu bag, plug it into the wall oxygen, and crank the flow meter up to 15 liters to fill the bag with pure oxygen and secure the mask over their nose and mouth. You are now physically breathing for the patient. Managing a true clinical crisis means you are executing immediate mechanical airway interventions while simultaneously anticipating the next step. You keep the patient oxygenated while the response team prepares the pharmacological reversal. That reversal agent is naloxone, commonly known as Narcan. It is an opioid antagonist, meaning it is designed to find the specific receptors in the brain stem and forcibly remove the narcotic molecules. The second that antagonist hits the central nervous system, the physiological reaction is violent. Every single molecule of pain medication is knocked offline at once. The patient wakes up from being completely unresponsive to being in absolute agony. Their heart rate skyrockets. They become highly agitated, and almost universally, they start vomiting. This is exactly why turning on the emergency bedside suction is a non-negotiable safety measure before the antidote is even pushed. This graph illustrates the pharmacological catch that catches out so many nurses. It plots the short 1 to 2 hour half-life of naloxone against the much longer 3 to 4 hour duration of the opioid. The antidote wears off long before the narcotic does. This creates a time gap where the patient can slip right back into respiratory arrest, a phenomenon called re-narcotization. The sixth and final step of clinical judgment is evaluating outcomes. If you give the Narcan but fail to reassess the patient continuously over the next 2 hours, the initial intervention was useless. You must be fully prepared to administer a second or third dose. Surviving the NCLEX and practicing safely at the bedside comes down to a few core rules. Filter the noise by prioritizing your ABCs. Always follow the AIR rule. Assess before you intervene, and burn this physiological fact into your memory. Sedation always precedes respiratory depression. If you're ready to master the logic behind the interventions, hit the subscribe button below and visit SuperNurse.ai for study guides and tools designed to clear the muddy waters of nursing theory. Clinical judgment transforms textbook knowledge into a precise cognitive process for the bedside. It allows you to recognize life-threatening patterns and act with confidence when the monitors start beeping. Keep thinking critically, and we'll see you next time.